Hello and thank you for joining today. My name is Michelle. I'm the current second-year oncology pharmacy resident at Monument Health, and today I'm going to be discussing my project, the analysis of pharmacist integration in the prior authorization practice model in an outpatient cancer center. I do not have any conflicts of interest in relation to this presentation. And my learning objective for you today is to identify the potential roles for pharmacist integration in the prior authorization process and associated financial impacts. I wanted to start off providing some brief background information related to the study setting, Monument Health Cancer Care Institute, for those of you who may not be as familiar with this facility. So Monument Health is the only large cancer center in western South Dakota, providing care for areas of North Dakota, Wyoming, Nebraska, South Dakota, and Montana, and we are a Mayo Clinic Care Network member. We have 5 medical oncologists at this time and 3 radiation oncologists, and we have 24 outpatient infusion rooms for oncology use. Next, I'm going to dive into some background information related to prior authorizations. So health insurers use a type of utilization review called prior authorization to determine medical coverage for individual patients. And authorization processes may take anywhere from 1 day to 2 weeks or even longer, depending on the specific authorization request and insurance company. And these authorizations can impact payers, providers, and patients by controlling delivery services, payments, and reimbursement amounts for medications. Right now, a pharmacist isn't included in the authorization team at Monument Health Cancer Care Institute, but previous studies have shown significant cost savings with pharmacist involvement in the prior authorization process, which I'll discuss a little bit on the next slide. So there was one study conducted within a VA healthcare system that assessed pharmacy resident involvement in the PA drug request adjudication over a 12-month period. And this study found a total direct cost savings of around $169,000 with a mean cost savings of around $4,000 per request. They did also note in the study that 9.5% of included prior authorization drug requests were for oncology medications, so some of these medications were related to our practice setting. In relation to Monument Health, then, key stakeholders within the PA process felt it would be most beneficial to have a pharmacist review denials. So the purpose of my study was to assess the current PA process at Monument Health Cancer Care by having a pharmacist assess authorization denials and to assess whether pharmacist interventions could be made to improve the efficacy of authorizations and obtain denial approval, along with identifying any processes that could be implemented to prevent future denials and placing a focus on potential cost savings from these interventions. With that, my primary objective of my study was to evaluate the financial impact from pharmacist intervention with denials, and my secondary objective was to determine the potential impact of pharmacist involvement in the authorization process based on specific denial trends discovered. My study was a retrospective, descriptive, observational study with real-time pharmacist interventions made on denials as deemed appropriate. I did a chart review from March 1st, 2023 to August 30th, 2023, so this was a 6-month study period total. And I included patients 18 years of age and older who had an oncology diagnosis and an active denial for an oncology-related medication at Monument Health Cancer Care Institute. For my included patients, I had 38 total patients, and I had 57 total denials, so some of those patients did have multiple denials. One data point I collected was the denial code. I collected this to help assess if there were any specific codes that we could filter out as pharmacists to help find the code where we could have the most impact in the future. Here is a breakdown of each of the denial codes I collected and the total number of each code. Here are more denial codes I collected. Of note, some of these denial codes do also have subcodes called remark codes, which are similar and sometimes do display an additional reasoning for denial, such as the NDC code was not correct. Now I will transition into the results of my study. So pharmacist intervention was possible on 8 of 57 total denials, so only 14% of the total denials. While the percentage of total denials was somewhat small, the estimated 6-month cost savings from pharmacist-led interventions was still significant at around $93,000. This chart here is a visual representation of the cost analysis comparing the dollar amount for denials where pharmacist intervention was possible to the dollar amount of other denials. To further break down those results, there were 7 interventions made under that denial code C016, which was our most common denial code for issues with billed national drug codes or NDCs. 6 of those 7 interventions under this code were for NDCs billed for a trastuzumab product, Ontruzant, which ended in 99 but needed to end in 01 per the manufacturer's billing recommendations. The pharmacist then discussed this with the billing team, who changed the NDC in the system and rebilled the medication. And an additional denial under this code was an obsolete NDC billed for Aloxi, and this obsolete NDC ended up being removed from the billing system, and we rebilled this medication to resolve this error. Lastly, we had 1 intervention made under the denial code C0197 for the incorrect brand name of medication being billed, specifically the incorrect bendamustine brand. The brand name Belzapro was billed, but Vivamusta was administered. For this, a ticket was placed to ensure each bendamustine product has a separate billing code or J-code, and the billing team was notified to rebill the medication. In conclusion, pharmacist involvement with review of select denials may lead to significant cost savings for the institution, and pharmacists at Monument Health Cancer Care Institute may provide the most impact by reviewing denials related to NDC codes or J codes. However, remaining denials are not appropriate for pharmacist intervention at this time. Potential future directions are to consider developing a process for pharmacist review of denials related to NDC codes or J codes, and to consider implementing process improvement measures with the billing team to help prevent specific denials and to help them recognize certain denials so they can be quickly resolved. That concludes my presentation. Please let me know if I can help address any questions. Listed here are my references.